and I yield back.
The gentleman yields back. The chair now recognizes Dr. Burgess for 5 minutes for questions.
And I thank the chair, and I do want to thank our witnesses for being here and for your forbearance and what has been sort of a disjointed day. Dr. Furr, I don't know if you were here earlier in the hearing, and I talked about one of the bills that's subject of this legislative hearing, the Provider Reimbursement Stability Act of 2023. Current Medicare fee schedule, we've heard it over and over again, is unsustainable and unpredictable. This is due in large measure to what's known as budget neutrality. The mechanism often leads to across-the-board cuts and make it harder for practices to survive. So with what you've heard about that this morning, can you speak to how provisions in that legislation would stabilize and promote accuracy within the physician fee schedule?
Yeah, we need to get where the physicians are not going against each other, and that's what budget neutrality does. So I think we definitely need to have that conversation because that definitely needs to change. And I think part of what you've got in there, changing the cap or where that changes, is incredibly important, and I think it would go a long way.
So that threshold has not changed since 1992, and the adjustment for constant dollars and the Medicare spend currently would result in a significant increase in that threshold, and that you feel would be beneficial to the practicing physician?
Yes, sir.
So, Dr. Pat, I can't thank you enough for being here. I know you had to ride the train late last night, and it was a lot. It was a lot for you to get here, and we really do appreciate that. In your written testimony, you mentioned examples of how consolidation leads to rising healthcare costs. Right now, I'm working on a discussion draft that would allow for physician-owned hospitals that are 35 miles from an existing hospital or critical access hospital to open or expand. And I'd like to remind everyone this is a draft. I'm working on a few technical changes, but let me just ask you the general question. Do you think physician ownership could be beneficial where healthcare is limited?
I do. Would be very supportive of that idea.
A very succinct answer. Dr. Furr, let me ask you the same question.
You know, physicians, most family physicians can't afford to run a hospital, but if they can't afford it and own it, I have no problems with that.
But who better to establish a facility in a rural area or an underserved area than someone who actually knows what a hospital is supposed to be and what a well-run hospital looks like? And the fact that we are precluded from that activity by virtue of our professional degree, and people on this committee have heard me say it over and over again, it is wrong that a hospital can own a physician and a physician can't own a hospital. It makes no sense. In a free country, it should not be that way. I do know that there are concerns on both sides of the dais. But I will just say, Mr. Chairman, before I yield back, I think this solution allows physicians to maintain activity in the business of healthcare while providing patients access to the care they need, and will allow doctors to continue to be able to afford to stay in practice when they have so many things working against them. In the interest of time, I'll yield back.
The gentleman yields back. The chair will now recognize Mr. Cardenas for 5 minutes for questions.
Thank you very much, Mr. Chairman and Ranking Member, for holding this very important hearing. I agree somewhat with some of the comments my colleague just made. It seems like in this country you can be a lawyer and own the practice, the law firm, but if you're a doctor, you can't own a hospital. Gosh, it sounds like we trust lawyers more than doctors in this country. But anyway, hopefully we can get to some good policy on that. Really appreciate that. This Congress, I'm proud to co-lead the Providing Relief and Stability for Medicare Patients Act of 2023, along with my Energy and Commerce Committee colleague, get this, Republican Bilirakis. Yes, I'm a Democrat, he's a Republican, and we're co-leading on that bill, as well as Representatives Murphy and Davis. This bill would mitigate significant cuts to office-based specialists by increasing non-facility practice expense relative to value units, or RVUs, for procedures performed in office-based settings that utilize high-tech medical devices and equipment. I believe this is important to ensuring that we preserve access to office-based care settings, many of which face a very real possibility of closure or consolidation. Analysis by health management associates have found that office-based specialists, including cardiologists, radiation oncologists, vascular surgeons, and radiologists, have been subject to cumulative cuts under the physician fee schedule since 2006. This is simply not sustainable, and I worry that patient care will suffer because of it. Our focus should be on building robust systems that ensure our communities can access the care they need. I just spoke to an oncologist who owns a small practice, and he was mentioning how difficult it is, but I interrupted him. I said, okay, if your practice were to close, how far would your patients have to go to be able to get your service? He said 60 miles in one direction, 95 miles in the other direction. That's rural America. And I say that because I care about access for all Americans. I represent part of Los Angeles. You can go a mile or two in any direction, you're gonna find doctors. You can go a few more miles, you're gonna find oncologists, et cetera. So I just wanna point out that please don't think that if we represent a big city, we don't care about rural America. And as well, I don't think that my colleagues who represent rural America don't care about people in big cities either. I just wanted to point that out. I have a question for Deborah Pat. Dr. Pat, in your testimony, you note that decreasing reimbursement causes a chain reaction that results in provider network inadequacy, decreased access to care, inability to manage staffing shortages, and decreased quality of care for American seniors and other Medicare beneficiaries. What's the impact of these sustained clinical labor cuts, especially in medically underserved communities?
Thank you for the question. I think that these cuts will result in doctors not being able to staff appropriately, which overburdens the doctor and makes doctors exit the workforce. I think we've observed this. Then when practices are subject to close, there's frequently consolidation of medical care. The natural consequence of that is that it drives up healthcare costs. So I think that there's a number of factors that all influence access to care and the cost of care at the end of the day that will be harmed by not making change today.
Yes, thank you. It's important that we focus also on healthcare workforce so that we can get an adequate environment out there. A physician survey in my home state of California found that 87% of physicians expressed that low Medicare reimbursement and high costs to practice in California are negatively impacting physician recruitment and retainment. And I'm sure that's not just for California. That's for all the rest of the country too. Congress must work collaboratively to ensure that physician workforce is equipped to address the needs of communities they serve, especially if we want to ensure that our healthcare workforce is as diverse as the community that they serve. Question for Dr. Fiedler. In your testimony, you mentioned that evidence suggests that reductions in Medicare physician payments rates potentially affects who enters the medical profession. Can you expand on this, and what do you expect that the impact would be on workforce diversity?
There is some evidence that, and particularly regarding specialty choice, but it likely also affects how many total people enter the profession. I think the question then is how large those effects are and how to balance the resulting increase in supply of physician services from higher payment rates against the costs that those higher costs impose on taxpayers, on beneficiaries, and potentially on people with private insurance.
Wow, sounds like we need a better efficient system. Thank you very much. I've just run out of time. I yield back.
The gentleman yields back. The chair now recognizes Mr. Carter from Georgia for 5 minutes.
Thank you, Mr. Chairman, and thank all of you for being here. As we all know, we've got a healthcare worker shortage here in America, and we certainly have it in the state of Georgia as well. As a consultant pharmacist in nursing homes for many years, nursing homes have been especially impacted by the healthcare shortage, and it's something that I'm very concerned about. Healthcare provider shortage is one of the biggest challenges facing our healthcare system and our nation right now. We all know that. In fact, there was a recent survey that said that the U.S. will face a shortage of up to 139,000 physicians and advanced practitioners by 2033, including shortfalls in both primary and specialty care. You know, I don't know that it's the total reason, but I would submit to you that more than any other agency, that the FTC has failed the American public by allowing consolidation in healthcare like they have. I would submit to you as a pharmacist that the primary reason for high drug costs is the consolidation, the vertical integration that exists in the drug pricing chain, where the insurance company owns the PBM, that owns the group purchasing organization, that owns the pharmacy, that owns the doctor. Do you, Dr. Furr, do you know who employs the most physicians in America right now?
I'm not for sure, but I would guess United Healthcare.
You are absolutely 100% correct. United Healthcare employs more physicians in America now than any other organization. And it's not just pharmacy. It's also in the healthcare system. It's the hospitals. Now, look, folks, I'm not opposed to anybody making money. I know we live in a capitalistic society. I get it, and I understand all that. We had a meeting, Mr. Chairman, here with the Energy and Commerce Committee. It wasn't a hearing, it was a meeting. We had the Congressional Budget Office, the CBO, we had the director, and we had 20 staff members. I asked them that question. I said, give me one example of where consolidation in healthcare has saved money. Crickets, nothing. One example where consolidation in healthcare has saved money. Whether you're a Democrat, a Republican, or an independent, you all want the same thing in healthcare. You want accessibility, affordability, and quality. And consolidation has done away with all of those, I would submit to you. Now, I'm not saying that we don't have quality health care. We do. We've got the best health care in America and in the world, right here in America. But the consolidation that has gone on, you know, I don't expect for you to tell me, but I'm going to tell you who I'm voting for president. And that's going to be Teddy Roosevelt, because we need somebody back here who will bust it up. And he can do a better job dead than most of these people can alive. I'm just telling you. Let me ask you, Dr. Furr, what kind of misaligned incentives do you think that we have right now in healthcare that's causing some of these shortages?
Well, I think so many of the things, and the things that when you talk to our physicians, our biggest thing is administrative burden. And as you know, working as a pharmacist, you know, when administrative burden started out, that was to take care of high-cost items, so we weren't overusing PET scans and paramobility devices. And now we're doing pre-authorization for generic drugs, so that just because they changed their formulary, a patient that I've had on their diabetic hypertensive medicine for years is well controlled. I get a letter from the program, from their plan, saying we're no longer going to cover that drug. And then they won't even tell me what drug they will cover. So then I've got to call the pharmacist to say, what drug do they cover? So we don't know. You've got to send it in, and then we'll let you know if it goes through. So you might have to do that 2 or 3 times. There's no transparency there. At least give me a half a shot by telling me what you're going to cover. And they might be doing it to save 2 or 3 cents on the dollar. And then for what little savings they get, that patient might wind up in the emergency room. That patient might have to make 2 or 3 visits while I'm changing their medicine to get them back under control.
And not only that, and I will tell you, when I still own my business, when I still own the pharmacies, I had an employee totally dedicated at nothing but prior approvals. That's all they did was prior approvals. And people, and it decreases compliance. Because, you know, I get a prescription from the patient, from the doctor, and I'm sorry, I can't fill it right now. I got to call and get a prior approval on this. And then it's 3 or 4 days, and they don't come back, and they don't get it. They go without it for 3 or 4 days, and a lot of times they just don't come back, period. I'm telling you, Teddy Roosevelt, that's who we need to vote for. Mr. Chairman, I yield back.
Gentleman yields back, and the chair recognizes the gentlelady from Illinois, Ms. Kelly, for 5 minutes for questions.
Thank you, Chair Guthrie and Ranking Member Eshoo, for holding today's critically important hearing. The 2nd Congressional District is one of the biggest districts in Illinois, covering a travel distance of approximately 3 hours from the northern part in Chicago to southern boundaries. It encompasses a diverse range of area from urban, suburban neighborhoods to rural. I have approximately 2,000 farms dotting the landscape of my district, and frequently I receive feedback from constituents across the district, the challenges they face in assessing health care, but this concern is particularly pronounced for those living in the rural corners of my district. Throughout today's testimonies, we've heard that access to physician care for Medicare recipients has shown remarkable resilience in the face of challenges posed by the existing physician reimbursement model. However, it remains a well-documented fact that individuals residing in rural areas, particularly those in communities of color, frequently encounter obstacles when seeking high-quality health care. These difficulties arise from a multitude of factors, with workforce shortages, especially the challenges in retaining physicians in those underserved regions, standing out as a prominent and persistent concern. Dr. Fiedler, can you elaborate on how the proposed modifications to, Medicare's physician payment system, which you discussed during your testimony, might enhance access to health care for Medicare beneficiaries in rural communities? Excuse my voice.
So there are, in terms of rural communities in particular, broadly speaking, the Center for Medicare and Medicaid Innovation at the moment is considering and it is working on specific ACO models that would provide more generous spending benchmarks to communities that have been historically underserved. And I think the hope is that those sorts of structures will allow the providers participating in these models to invest more in the care for those communities. I think those types of efforts are still at the early stages, and so it remains to be seen whether they'll have the intended effects, but I think that's an approach worth watching. I think these types of provider-side interventions are worth exploring. I think it's also worth looking at interventions that would target sort of underserved beneficiaries and disadvantaged beneficiaries themselves. So one specific opportunity, for example, is improving the Medicare savings programs, which provides cost-sharing and premium assistance to lower-income beneficiaries.
Okay, thank you. Dr. Pat, with the end of the public health emergency, CMS has decided practices can no longer deliver oral cancer medications to patients. How has this impacted cancer patients' access to treatment, specifically, again, in rural communities?
Thank you for the question. I think this is a really important one that's happened with the conclusion of the pandemic. So, it's an amazing time in cancer care, actually. Not only are we able to frequently control cancer or cure cancer, but people are able to live their lives where they work and sleep in their bed and eat dinner with their spouse and pick up their kids from soccer practice. They get to live. And it's amazing. And a lot of that is because the therapies that we give are chronic in nature, oral therapies that they take chronically. For patients, especially rural patients, like the patients you mentioned in your district that have to drive for health care, are no longer able to receive mail order drugs from their doctor, which means if you're on an oral oncolytic like axitinib or Verzenio or another drug that you take chronically to control your advanced cancer, that you alone have to stop your daily life, drive the 3 hours into a clinic to pick up your medication, drive your 3 hours back. And in that, you still get to have your cancer controlled, but you don't get to live your life. Because if you're a rancher or a housewife that lives in rural America, you have to drive and disrupt your daily life in order to receive care. This is in contrast to the time before, during the pandemic and before the pandemic, when patients could receive their oral medications delivered to their homes. And that makes it a lot more convenient. So this is a challenge, and it's a particular burden on rural Americans. And it's growing because, thankfully, due to innovation and America's investment in innovation, we have a lot of oral therapies that control cancer chronically. This represents about 30% of the cancer therapies we give today, but we think it's going to grow to 60% in the next few years. So this will be an increasing burden for rural recipients of health care, and particularly cancer care. I think that it would go a long way to help the health care of rural Americans to make official policy to change that, to allow patients to get their drugs by mail from their doctors.
Thank you so much for your